About some information for your CEUs and CMEs. I don't have anything to disclose related to this discussion. We're going to be talking about substance use disorder assessment and screening today. And I'm going to go over a couple real big areas in just a few minutes. So it's a lot of information to pack into about a 20-minute overview. But essentially, I want to address why it's important to utilize a screening / assessment procedure. So I'm going to go over some specific models. Within that, I'm going to talk about specific screening instruments, and then very briefly show you some comprehensive assessment instruments so that you're able to understand the difference between screening and assessment, and how this could be helpful for you to begin to apply in your setting. The first thing, though, that we always like to kind of set the stage with is some of the data, the epidemiology regarding substance use, just to highlight the fact that this is really a prevalent issue. And everyone on this talk, I think, is aware because you treat individuals with substance use disorder, but in your facility, it may not be standard or routine to include screenings for substance use disorder. And I'm hoping that one of the takeaways from today is that it's really clear we need to have that as routine care regardless of setting. Because you can see that the numbers are quite high. 136 million, or 52% of Americans, will report currently using alcohol. 16.5 million will report heavy drinking, and approximately 24 million will report illicit drug use, marijuana being the most common of those substances. So it's a large number of people that are engaged in using alcohol or illicit substances. Now, that's different than the amount of people that can actually access treatment. Once it rises to the level of problematic use or substance use disorder, only about 8.9% of those, or 8.9% will need treatment. And of those that need it, a very small percentage actually receive it, 10%. So that means that a large percentage of individuals will go without access to specialty addiction treatment. And that's because of, there's tremendous stigma around working with these individuals. It can be quite expensive. We don't have a lot of people that are wanting to do what you guys are doing today to learn about how to treat it. And so it's just not that available. So the bulk of the substance use treatment does have to occur in things like primary care settings or non-specialty settings. So you can see that when we look specifically at primary care, 82% of adults and 92% of children at some point over the course of the year are going to see a primary care specialist. 55% of these 1 billion office visits are primary care visits. And then we also have over 130 million in the ED. So this is a lot of opportunity in which medical providers are going to be able to catch individuals with a substance use disorder, ideally before it becomes a serious problem, but even once it has become a serious problem, be able to intervene to help them, because the access to the specialty care is pretty limited. And so if we can catch it on the primary care side in the emergency rooms, we might be more effective at actually catching it before there are serious consequences associated with it. So that brings us to why it's important to have a screening and assessment process, regardless of your location, regardless of your role. Screening really helps providers understand what patients need, so what's going on with them, and match them to the right services efficiently. It also serves the purpose of helping us to track symptoms over time so that we can adjust treatment accordingly. So if we don't have a way of sort of checking in, kind of the way we take blood pressure or vitals at the beginning of every session, we need to have some sort of a process for checking on use behavior. That way we can tell if anything major has changed. That's really important. So where do we start to apply the screening and assessment pieces into our routine piece of care? Well, there's a couple other I guess paradigms to consider. One is using an episode of care model. So rather than thinking about patients as only coming to us in crisis or coming to us when they're actively having some problematic use patterns, thinking about all of the work that we do is falling into specific episodes of care to treat a particular condition. So most episodes of care are between 4 to 6 weeks in duration. And so we need to have a screening and assessment process to trigger when someone enters an episode, when someone leaves, and for how long they're going to need to be in there. So we really need to be using our screening procedures throughout the course of the episode of care and across the continuum of care, because recognizing that patients are going to most likely be in more than one episode with more than one provider at any given time, or they're going to need to transition between episodes. They're going to go from a more intense level to a lower level of intensity and eventually to community or the other direction. So recognizing that patients are going to move across the continuum and that within each one of those, with each provider and with each one of those time points, we need to be thinking about how we're defining this particular episode with them, how long it's going to be, and then what types of screening do we need to apply as part of routine care to be able to make that determination. So this is showing you a breakdown that falls in line with ASAM, which I'm going to introduce as a large model for assessment. And it shows that the vast majority of people, when they're screened, are not going to need any intervention. They might need like a positive health message because on the screeners, they're going to show that they're kind of falling into the low risk or no use at all category. That's the majority of people that we're going to come across outside of specialty care, right? So in a primary care setting. There's a smaller percentage that are going to fall into that risky category, and those are the ones that we really want to intervene with sooner rather than later, because if we can intervene there, then we can maybe prevent it from becoming at those higher levels. And then at the top, you can see arranged by color and by definition of risky, harmful, and dependent, scores on certain instruments. So that's really nice that we have standard norm referenced screeners that we can provide to every single person that walks into the building and get an idea of which part of the pyramid they fall into. And then that will help us to match what intervention we're going to provide to them. So ASAM is one system or one model that actually New Mexico is a state that endorses. So we're considered an ASAM state that we should be using to be able to assess these patients and then place them into an intervention match. So it uses multiple domains. It starts with some of those screeners that we talked about, which can then lead to a diagnosis, determination of severity, and then an evaluation of their readiness or relapse potential, which has to do with sort of defining their stage of change, intoxication and withdrawal, biomedical, emotional, behavioral, treatment and acceptance resistance, relapse potential, and recovery environment. And then based on how they score across those 6 different dimensions, it will help us to make a decision about what level of care the individual will need. And then another nice thing about ASAM is that it lines up with our CPT codes. So all of the services that we provide will fall across this continuum of care, right? Going from our more severe, like medically monitored acute detox or intensive inpatient services to general inpatient, residential, and then IOP and outpatient. So across those different levels of the system, ASAM can help us make a clear determination what level of care the patient is going to need. And this is important because when we don't make evidence-informed decisions, so using a standard a screening and assessment model to make placement decisions, we can actually be detrimental to treatment. So these are some studies that are showing how undermatching will worsen no-show to treatment. And when people don't show up, then they're not likely to get any better. And so it's really important that we make an appropriate match, that we recommend that people get the right intensity of treatment. And the same thing on the other side, that if we undermatch, we can have poorer outcomes in regards to dropout, and maybe not get people to step down to a lower level of care as effectively. So matching people, you can see in the middle category, were the most successful in terms of getting them to a step down appropriately, or at least maintaining them at the same level of care versus some of the others. They needed to be bumped into a higher level of care, or were not successful at being stepped down through that continuum. So it's really important that we utilize some formal assessment model to help us make those decisions. And ASAM is one of several, but it is probably the easiest to get training in. It is widely available, and it is endorsed by our state, so we should technically be using it. It is proven to be highly reliable and feasible for use across populations. It has good validity and predictive validity. And it helps us to make sure that we're not undermatching or overmatching, so that we can make recommendations to patients. Should they stay with us? Should they go to a higher level of care? Are they ready to step down to a lower level of care? Another model that can be helpful is, and that has actually been applied in a lot of emergency rooms to positive effect, is the SBIRT model. And that stands for Screening, Brief Intervention, Referral for Treatment. So this is a model that, again, says everybody should be assessed for risky substance use using standardized screening tools, which I'm going to show you some of those here in a minute. That the screening should be done in every or any healthcare setting. So that could be emergency room, primary care, the dermatology office, and anywhere we should be screening for this. And that depending on how people respond to the screening tool, if they come into that risky zone, sort of the higher levels of the pyramid, that will determine if we're going to give them a brief intervention. Some people in that just risky zone, brief intervention is sufficient. Or if they're in those higher tops of the pyramid, those darker blue colors, then we also want to consider adding on a referral to treatment. So what additional treatments might they need or benefit from to help decrease their risk? So the SBIRT model goes through these elements. You provide information and feedback about the screening results. You give them a brief screening. You give them information about what their results were. You talk a little bit about their understanding of their use, and then try to shift their perceptions about their use. So they might think it's fairly normative, or in their culture, their environment, it's normal to use at that level or that frequency. And as the healthcare provider, this is an opportunity to kind of coach them around, well, actually that isn't recommended, and here's why. Encourage a discussion on how continued use at that level could actually lead to injury or may start to cause consequences in their life if it hasn't already. Advise them in clear but respectful terms how to start to decrease their use, hopefully to lower levels or possibly even abstinence depending on the substance. And then go through any change skills that might be helpful for them, like logging or tracking their use, or helping them to measure a standard drink. There are a lot of skills that could be taught very briefly that could help them in starting to decrease. And then coming up with a method for follow-up. So do they need to just come back and see you for another check-in if they're kind of in that risky category, or do we need to start getting them scheduled for some specialty care? I've given you a link to the SBIRT app, which you can download, and it goes through all of these components. There's a lot of information on SBIRT that's widely available and free on the SAMHSA website. There's even an SBIRT toolkit if people are interested in getting more information about it. But in general, it just like ASAM, it recommends that screening is routine and done at every encounter, and that it helps to determine which category people fall into. If they're low risk, then nothing else is warranted. If they fall into that moderate to moderate high risk, then we want to be giving them education about their use and maybe even talking through using some motivational interviewing techniques, some of that change behavior. And then if they fall, make sure that we're getting them linked to the appropriate level of care, maybe using a further assessment under the ASAM model to be able to determine should they maybe even go to an IOP, or would residential be preferred, depending on what that assessment tells you. So now I'd like to shift into how you could apply some of these models by using standard screeners. Now, a screener is different than an assessment. It is something that's meant to be brief and easy to apply to kind of anyone. It targets unhealthy or problematic substance use, and it could be specific to alcohol or other drugs or both, depending on the screener. Its goal is to really detect the entire spectrum of unhealthy use so that we can understand what the next steps are going to be for them. So making sure that we have a higher likelihood of matching them to treatment for improved prognosis. So screenings should occur at the time of service encounter, usually like before you actually see them. They're given one of these screeners and then you look at the results with them. It should filter for substance use, or it could also filter for mental health concerns. So the PCPTSD, the PHQ-9, the GAD-7, those are all mental health screeners that are routinely used. It can be used in a variety of settings and is meant for that brief intervention format. It can also be used to track symptoms over time. So something that you could do every time you see the patient to see is there any change, and it will assist in that referral. That's different than assessments. Once someone has been screened, so for instance, the PCPTSD is 4 questions and it's just a screener. It's kind of a yes or no outcome. And if they answer yes to any of those 4, that would trigger an assessment for PTSD. By itself, it is not an assessment. So that's the difference. Assessments tend to be much bigger, more complicated. You're gathering a lot more information to develop a bigger view of what's going on. So that ASAM model would fall into the assessment category. So it's a much bigger gathering of variables. And they have assessments that will cover both mental health and substance use disorders, or those that will pull them apart. So just for mental health or just for substance use. But they're meant to help us to really get a clear diagnosis, to do the differential, and then determine a level of care. They're also really helpful for identifying what strengths or problem areas to target for ongoing treatment. So the screener is just kind of getting them in the door. Is there a problem, or no, there isn't a problem? And then the assessment is helping us to refine what specifics about the problem we're going to need to target and we're going to need to work on for that treatment plan and that relationship. So in terms of screening tools, you have a number that you can pull from. I've included here only the ones that are public domain, so that means that they're free. You don't have to pay anything to use these, and they're normed on a large population of people, and you can use them in most settings. So the cage, we don't use that often, but it is widely available. It's just 4 questions. It's very easy to administer. It gives you a score of 2+ and leading to the possibility of a diagnosis of a substance use disorder, specifically alcohol. It can identify unhealthy drinking in men or women based on frequency of use per day or per week. So it gives you the recommended amount. It also helps people to think through their servings and gives a nice little chart of standard drinks so that they can make a better decision of how many SDs they may be having. So it stands for cut, annoyed, guilty, and eye opener. So it's just a simple yes or no, and then a question of 2 or higher would trigger a positive on the cage. The AUDIT and AUDIT-C are much more commonly used, and those are also for alcohol. They stand for the Alcohol Use Disorder Identification Test. It was developed by the WHO to collect more information, so sort of in a jumping off point from the cage. The only difference between the two is the AUDIT-C is just the first 3 questions of the full audit. The audit is 10 questions, and the AUDIT-C is the first 3 questions of the full audit. And so you can, with the AUDIT-C, it's a 3 or more is positive for women, 4 or more are positive for men. And on the audit, the full audit, it's for men or women, 8 or more. So it looks like this. The nice thing about the audit is it's not just a yes or no. It gives you a wider continuum of frequency. And that gives us a little more specificity. So you can see the first 3 questions is the AUDIT-C, and you're welcome to use that if you only have a few minutes. But if you'd like to collect more information, it's only 10 questions, so it's nice to use the full audit and get the whole score. This has good stability in terms of being able to use recurring, as well as at longer time points. So the AUDIT-C is good if you only see them once every 6 months. It's also good if you're having them do it every single week. The DAST stands for Drug Abuse Screening Test. Like the audit and the AUDIT-C, it comes in 2 different versions, a short version of only 10 questions and a 20-item version. It also has an adult and an adolescent version that you can use. The nice thing about the DAST is it's not specific to frequency of use as much as it is looking at consequences of use. So here we're going to get a little more specificity to actually diagnosing, is there functional impairment related to their use? And it's not specific to alcohol or a drug. You could use it for either or both, and it aligns with ASAM criteria. So that means that the score that someone gets on the DAST is going to tell you the recommended level of care per ASAM guidelines. So this is a really great one for entry, so in terms of a screener for entry into care, to help us determine, are we actually providing the right level of care to this person? Because if they're scoring in the residential or higher category on the DAST, then maybe continuing with outpatient care is not going to be sufficient. We want to look at other supports for them. The INM Assist doesn't stand for New Mexico, it stands for NIDA, Modified Alcohol, Smoking, and Substance Involvement Screening Test. This is a great assessment tool. It is web-based and interactive. It also aligns with ASAM, and it provides links for resources under the expert model. So it's this awesome combination of a screener telling you if somebody has problematic use behaviors. It tells you the level of care that's recommended for them based on ASAM criteria, and it links them to brief intervention and other treatment referrals in their community utilizing the expert model. So it's kind of the best of all worlds. The nice thing about it is interactive. You can print out the paper form and give them the paper form if you like, but you can also, if you have a tablet or you have a way of having them do it on their phone, they can do it electronically and get really all of the benefits that are part of the INM Assist. It has 8 initial screening questions that evaluate for 10 different substance classes. And then depending on what they say yes to, it goes into more detail. So if somebody really only has a problem with alcohol, for instance, or only has a problem with heroin, it's only going to ask them questions specific to those substances, versus if they say, yes, I have a problem with all of these 10 substances, then it's going to give them the full screener. So it's nice that it has that skip option. It doesn't make everybody take every single question. It can be completed by the patient or it can be completed by you. So you could actually have it pulled up on your phone or your tablet and ask them the questions and do the skip tool and still use the web interactive component to it. So I've given you the link here where you can find it. A couple other screeners, or what we would qualify as what's called symptom trackers, are the COWS and the CEWA. And these are things that are clinical instruments that you guys probably already use that help you to determine level of withdrawal from opiates or alcohol to make determinations at entry to treatment and then for ongoing purposes. And then the last screening tool that we all use is UA or UDA, UDM monitoring. And this should never be used in isolation, but it can be very helpful because all the other tools we've talked about are self-report. And so for people that really don't want to tell us what they're using, those can be less effective than something like a UDA, which is going to give us an idea of what they may have been using or might be problematic for them. but only within a certain window. So that's why it's helpful to know, depending on how you're sampling, if it's blood, saliva, or urine, the catchment window for how long the substances might still be positive in that collection sample. So thinking about how frequent you're going to use UDA can be helpful in terms of your ongoing process. And then lastly, I want to just talk about mental health screening and then assessments. So in addition to substance use disorder screening tools, it can be very helpful to add into your regular workflow some mental health screening instruments to help us catch and intervene effectively with some of the other conditions that people commonly experience with substance use disorder, like anxiety disorders, mood disorders, PTSD, and just general quality of life. So I provided some, again, some public domain screeners for you that I would highly recommend applying if you don't already. They can be very, very helpful, and the link on the SAMHSA website where you can get them. And then finally, to explain the difference between screening and assessment, comprehensive assessment components will include all of this. So it really is a thorough H&P or comprehensive initial clinical interview to collect all of this information, lots of different variables. It's also recommended that you include a collateral interview and a chart review, as well as some structured assessments like these that go into a comprehensive assessment. So once somebody passes the screening benchmark, and then we're going to go into an assessment component, we have to collect a lot of information. So it's a lot more detail that helps us to make a more refined determination of their diagnosis and what next steps would be warranted. I wanted to give you some examples of structured clinical assessments that are available. Some of these you do have to pay for, but if you feel like it would be helpful to have something that's structured and that's already been proven to be valid, here are some options for you. The Addiction Severity Index is free if you use the PDF version, which I've given you here. If you want to use the online auto scoring version, you do have to pay a little bit of money for that, but it's a structured interview and it assesses for a whole host of problematic areas, not just substance use. It's a very nice assessment. The brief symptom inventory is not public domain, but it's not that expensive. You can purchase a license to have it for a year or longer, and it can be administered with computer. And it assesses for a whole host of different mental illnesses that could be problematic for treatment. The OTI, Opioid Treatment Index, is public domain and free, but it is not available on a computer option. So you'd have to do this by paper. And it's very similar to the ASI, but it has a little bit more information about general health and other high-risk behaviors. So it's a nice option in addition to the ASI. The timeline follow-back form and Form 90 are super helpful SUD assessments, and they give us a really thorough idea of the frequency and duration and severity of someone's use behavior, and they can go hand in hand. And then the GAINS is another a symptom assessment that looks at sort of global severity in a number of areas. So I think I got us to 30 minutes, and I will